So we collected data and looked at the relationship between surgeries per 100,000 population and average electrical power consumed for each country. And on the other graph, the other axis, average life expectancy at birth, total years. So each one of these bubbles that you see on this graph is the population of a country. So you can see where China and India are, for example. On the y-axis, the data comes from the Lancet Commission on Global Surgeries, 2012 data. And so all of the surgeries per 100,000 population, what they focused on is the need for surgeries in these locations to really increase global health. What we've done is juxtapose that with our research on average electrical power consumed and the data that came out of the World Bank for all these countries. We normalized it, divided it by the population to get this unit of watts per person. So 100 watts is a consumption level that's similar to a light bulb. All of these countries to the left of this blue line, and I'll talk about the blue line in a second, all of these countries to the left are under a light bulb per person. What does that mean? That means in Uganda, if 10% of people turn on one light bulb, one extra light bulb, they have the possibility to bring down the grid. Well, turns out that not every city is going to have access to grid electricity at all the time. They have load shedding to handle that. But it also means that people can bring down the grid much easier, so they have brownouts, blackouts. On the other side, the countries which are a lot more watts per person, in fact, in the United States, we could have double of everything. We could have another hospital, another school, another house, absolutely double the consumption we have right now. We would not bring down our grid. It's called an electrical buffer in power systems. So what you have here before us is this idea of, if you are going to do a surgery, how are you going to power that surgery? And if you are going to have that surgery powered, and you need it powered for key things like anesthesia, oxygen, then how are we going to have that power reliable? And so we have for reference this 100 powers as an idea that a human being on a bicycle generator can generate 100 watts of electrical energy. And we'll come back to this issue. But without electrical power, regardless of where it comes from, you're going to have serious consequences to the average life expectancy at birth. Or you're going to have additional risk to patients in surgeries. And how do we quantify this additional risk? How do we model? How do we come to understand? How do we verify data that people do say is true? How do we have a model to know what was the cause of that? That's what this paper looks at. It looks at a complete model that both connects electrical energy and healthcare while giving us a chart where both types of experts can talk to each other. The energy expert can talk to the healthcare facility, and the healthcare facility can talk to the energy expert. How can we bridge these two fields that haven't really been bridged before? So what we did, since the data doesn't exist, and in the paper we talk a lot about, or at times, why the data doesn't exist. But what we do have is we have academic publications, peer-reviewed academic publications. So we reproduced 4 publications. One was published in Solar Energy 2010. It was a healthcare facility in Iraq. The cost of electricity for the system that they considered, and as you can see, it was a solar panel to DC, batteries to DC, a converter to go from DC to AC, and then the healthcare load was only 32 kilowatt hours per day a peak of 5.6 kilowatts in the entire year. That was the peak. So the cost of electricity is 26 cents per kilowatt hour. And they accepted an 18% capacity shortage so that their cost of electricity could be less. Another publication goes into this idea that you can save 50% on costs if you accept a 20% capacity shortage. So this seems reasonable. Many people accept a capacity shortage to be able to bring their costs down, their energy costs. They also argue that a diesel generator was not feasible at their location because there was no diesel fuel. And going back and forth on a bike carrying diesel fuel was not something that was going to be feasible in Iraq where they were located. So we reproduced this results, and then we graphed not just the energy capacity, we calculated the time capacity when in fact does the actual failures occur. Most people assume the failures would be at night. We'll go into more details later about that. In Bangladesh, the publication was in the academic journal Energy in 2010. And you can go through the actual paper of those details. In this example, they chose as the optimal system solar, wind, battery converter. And they did not choose a backup diesel generator as well. Their energy capacity shortage was 10%, and their time capacity shortage, the amount of time they were going to be failing, would be 6.6%, so less. The other two that we considered, one in the International Journal of Computer Applications in 2015, talking about an energy system for Ghana. We were very interested in their policy recommendation from this optimization energy system, that they suggested that the government provide 50% of the power, 50% of the time, all of the power 50% of the time, because then whatever the institute is, the business, the person at home, or the healthcare facility, they would then be required to provide the other half. Now, why this may seem on the surface to seem reasonable, this was their policy. There was no policy working with healthcare facilities. It's if the healthcare facility had no funding to provide electricity, this is all the electricity they would have. So let's look at that. When you look at this one, the cost was 12 cents per kilowatt hour. Very, very clever how they set up the power load so that the energy capacity shortage was 11%. But because there's a dry season and wet season in Ghana that's very clearly defined, almost 50% of the time, there is no electricity at this healthcare facility, if in fact they implement this energy policy recommendation. Now in Uganda is very different. This particular publication in 2012, it was actual real measurements. So we were able to obtain those measurements. And these measurements were measurements of when the grid failed and when the generator failed. So both have failed. Now the grid price is 25 cents per kilowatt hour, and the diesel price is somewhere between 75 cents to $11 per kilowatt hour, depending on how you're operating the generator. So when the grid fails, that $11 per kilowatt hour, and I'll mention this a couple more times later on, is so expensive, the hospital chooses to turn off the generator if they don't have a lot of appliances to run. Their energy capacity shortage is 4.1%, and their time capacity shortage is 4%. This is at a regional hospital that they have a backup diesel generator, and you will find when you interview many hospitals that they cannot continually run the diesel generator, especially those who have solar panels and battery converter systems and then have a backup diesel generator. Their diesel generator ends up becoming more and more, the costs become higher and higher, and they have to arrange medical procedures around the costs of the diesel fuel. And we'll come back to some of those issues later on. So we had these four systems and we modeled their electricity failure in terms of time.